Hello, this is Manny Barbosa, and it's another educational recording. This time is about open heart. I know that there's a lot of hospitals are struggling on how to put an open heart training program, especially if your hospital doesn't have any nurse educator, or if they hired a nurse educator who doesn't have even experience with open heart or any kind of curriculum development, because I know I've seen a lot of those where, my 31 years of nursing. So as that person who's really advocating for empowering staff nurses through education, where I used to work and where I came from, I've given all this training. So some of you probably will run into this video and you said, oh yeah, I know Manny, right? So for those who are looking for some sort of like an educational materials or video, well, my videos is different from other YouTubers because you don't see their face, but they're just putting a lot of PowerPoint slides. Me, I try to make sure that even my gestures or my examples, then you guys will be able to remember those. So at the bedside, then you do what I done in the past. All right. So again, guys, this is for open heart training. If you have been doing a CV nursing for a while, but you did not really get a formal training or education, then you might want to review this. It will really help you to understand it better. Of course, there's no such thing as one size fits all. Probably this is only good for the hospitals where I used to work, and your hospital is doing different, okay? But at least you get the sense of the basic information from basic to advanced. So what are your indications for surgery? Intractable angina, left main stenosis, unsuccessful PTCA, thrombolytics, VSD, and risk factors modification. For example, Mr. Smith is having angina in the past, and unfortunately, he got 2 stents already, right? He was told to go exercise, stop smoking, eat healthy, and at the same time, he's very non-compliant. He was also diagnosed with ventricular septal defect because when he was a kid, that wasn't got diagnosed because of the lack of access to healthcare. Some other countries actually have that same situation wherein not everybody was privileged to go see a doctor without paying, right? Because other countries, it's very expensive. And if they don't have money, then of course they probably didn't even have the chance to see the doctor. So now they come to the United States, then where everything is actually provided to our individual, then they get diagnosed with ventricular septal defect. So that would be a contributing factor. And of course, intractable angina, when Mr. Smith will develop another pain, chest pain, he will call 911, and then of course they will instruct him to take some aspirin, and when the paramedics gets there, they'll do a 12-lead EKG, they'll confirm it as ST elevation MI, they will call the emergency room nearby and route there, and so the ED will then have 60 minutes door to balloon as part of the initiatives of all the medical centers nowadays. So when the paramedics gets into the emergency room, they will prep Mr. Smith to go for cath lab. So what do? Then of course they will do a 12-lead EKG upon arrival in the emergency room. They draw blood, especially troponin, and then when the troponin is elevated, EKG is showing some ST elevation confirmed by the cardiologist, or they will actually refer to the cardiologist. And then the cardiologist will then alert the cath lab for possible PCI. So I just added some research outcomes here, that PCI versus cabbages. So the drug-eluting stents before that, the PCI was showing really high rates of MI and stroke. And then when you do a stent, it will reduce mortality, which is really great. But the question is, what if I already have stents all over my RCA and LCA? Then the only chance now is to open you and bypass. All right. So cabbages on pump versus off pump. So we do get a lot of the surgeons who are trying to either do the conservative one or do the more modern approach. So minimally invasive, sometimes they're just gonna open a, like those small incision in here, but some doctors that I used to work, they will open. So even when you think that it's just a big scar and surgery there, I think you have a better visualization of what's going on with the heart. So again, it all depends on your hospital. But my hospital, the surgeons are still doing the big cut into the middle of the chest. So again, guys, that's just my 2 cents there. So the rate of 1-year composite outcome with the off pump was higher than the on pump. Again, guys, this is a case-to-case basis. It's normally the preference of the doctor and how they see them recover. So preoperative cardiac surgery, nursing evaluation. So if your hospital has those RNs that are working with the cardiothoracic surgeon, they're actually preparing this patient for you. Or there is what we call the same-day surgery, or they're coming from CCU, for example, then they get prepped there, and then they go to OR, and then from OR they come to CVICU or surgical ICU with, that takes care of the cabbages. So again, guys, some hospitals are CVICU, some hospitals are surgical ICU. They just put them all in there. So outpatient and inpatient. So the baseline information for the post-op period, including physical, psychological, and emotional readiness. So what do I mean by this? Make sure that I believe, because where I came from, our surgeon, before he will do the surgery, there will be an instruction given to the patient. For example, taking deep breaths, holding the heart pillow, getting out of the bed after extubation or even before extubation, those kind of things. So those are the early mobility program that is actually being instructed to the patient, so that you'll get the buy-in of the patient cooperation, because the early that they move, the better for their recovery. And that's what we call the business acumen of what we do now, decreasing length of stay, decreasing the ventilator days. So the prior history, which may affect management, for example, if they have comorbidities like COPD, smoker, depression. Why? Because the tendency is it's kind of hard to extubate. And when it's hard to extubate, then the more problems that's something that we need to try to prevent, are the complications. And then, of course, living arrangement. If they don't have anywhere to go, for example, there are homeless patient, and if they're homeless, then of course, where are you going to discharge them to? So these are the things that they need to fix. I mean, we have somebody who's in charge with that, right? Social workers, case management. But I think as a nurse, I will be paying attention to this information so that there is a transition of care. That's what we call care coordination. And then, of course, relationship building. So some hospitals, the CVICU nurses will go meet the patient before the surgery, and so that they have an idea that this will be my post-op nurse. This is my nurse that I'm going to meet in the CVICU. All right. So again, it all depends on what your hospital set up for all this pre and post-op care for your open heart patients. So again, patients and family education. So where I came from, if they are in the waiting room, because as soon as the patient gets into the OR, they'll tell them to wait in the waiting room. So we ask them, everyone to be in, we invite them, all the family members, for an orientation into the room in the CBICU, wherein we show them the monitor, we give them orientation about the alarm so that they don't get panic if they hear those. And then of course the ventilator, they know that there will be a ventilator in there. Sometimes there will be a balloon pump. Sometimes there will be a CRRT machine. So the family, being educated on that as part of the expectations post-operatively, so that they don't have to keep asking the nurses. And then towards the end, we will ask the family members who's going to be the designated spokesperson, right? So that only one family member will be calling the nurse's station or trying to speak with the primary nurse, because if one and another family members will keep calling, then you're pulling that nurse away, which we don't have time to do that. So what to expect, the type of surgery, then of course before and after and during, so the equipment, the tubes, the line, the drain, and the restraints. So I discussed that a while ago. It's same way with the pain. Pain is so big. Thinking about like when you see the scar, or there will be like staples and everything in here. Right now, majority of the surgeons that I knew that doing this surgery, they're actually giving ketamine now, which is a very good pain management. So when they come out, when they got reversed, the anesthesiologist should have at least have some sort of like an emergency pain medication in there, just in case they reverse the patient at the bedside. So again, this is something that I want you to pay attention. Some hospitals, they reverse them right away in the OR. So in transit to CVICU, they are managing that pain because they're going to start waking up. And when they wake up, then they start moving, or sometimes they trash, those kind of things, trashing, like, agitation and everything. So that's when you really need to make sure that they understand and they're not delirious, right? So pain management is really important there, because some doctors don't want them to be like grabbing and all over the place, because they put a lot of pressure into their chest. And there's, of course, you have your epicardial pacer there, you have your chest tubes, either 2 or 4, and then, you have all your Swan gans or PA catheter. So there is a lot of contraptions attached to the patient that you guys need to watch out for. And mobilization is really essential. So some hospitals where I came from is 4 hours, where all the nurses are doing it before 4 hours or not more than 4 hours. So that's something that, again, quality metrics, because we found out that the earlier that you actually extubate them, the better, so that you don't have to paralyze, like that sedation, that propofol, you can turn it off, or Presidex. Some doctors will keep the Presidex, but because it really keeps them calm, especially for those patients with PTSD, like our veterans patient, for example. Then that's something that we need to reconsider. What are the contributing factors that could delay the extubation? Nutrition. So again, guys, this is something that you do not delay, because of you need some protein for muscle building and tissue recovery. So again, it's a case-to-case basis. Please check your institution, your hospital, because you need to address those, either tube feeding or diet, soft diet to regular diet. But before that, of course, you have to make sure that when you extubate the patient, you do your assessment, right? Your swallow eval, so that they won't be choking and potential for aspiration. So what are your pre-operative assessment? Well, I got this these slides because I did a lot of open heart training at Mills, way back in California. This is Mills Peninsula Hospital, and what we do there is we have to make sure that we have the pre-anesthesia testing. They do a lot of outpatient, follow-up before the schedule for surgery. And then, of course, the medication should take or not take prior to surgery, especially, for example, if the patient is diabetic, we instruct them to hold up their metformin, those kind of things. And of course, if they do get Lovenox shots, so those are the things that you need to confirm with the doctor before stopping it. They need to know all those, the Coumadin, or if they have some amiodarone before, I think they want them to continue that medication. So we do have the amiodarone protocol. So the advanced practice nurse will then evaluate the potential for the amiodarone. There's a lot of studies out there that it's very effective, proven effective to control your AFib related, post-op complications such as AFib with RVR. And of course, they will coordinate with the cardiologist if your amiodarone will be continued. So there's a lot of evidence-based practices out there now, but it's just a matter of like how are they adopting these changes based on EBP. So some guidelines, as I mentioned, with in preventing AFib, because why do we need some guidelines? It says there because we do have a lot of evidence base out there that's actually been studied and it's proven effective. So currently, right now, where I'm working now, there are just, I think we're just starting to do this. I think last year when our cardiothoracic surgeon finally implemented the amiodarone, giving amiodarone to our patient postoperatively. It increases the mortality. So, as we all know that when you have AFib, so I don't know if you guys are aware, but let me just make sure that I'm all right. So let's just say this is your left atria, right? And then the left atria, we do have this what we call appendage. So if you have an AFib, blood will then accumulate in here, right? When you have an AFib, you lose what we call the atrial kick, which is the 20% of your preload. So pretty much when the blood sits in here, tendency is it form a clot. And when you have an AFib with RVR, the tendency is for these clots to get dislodged, and it goes to the left ventricle, and then it will come out, and then it goes to your brain, right? So that's when we say that the increase of mortality and stroke happens. So again, guys, what do they do? Nowadays, they do a Watchman procedure. If you know what I mean by Watchman procedure, they have that kind of mesh like this. So they put this through endoscopically on the venous area on the right, on the femoral vein, and then they go into the inferior vena cava into the right atria, and then they will poke into the septum, and then they go here to the left atria, and then that's when they deploy your Watchman procedure. So again, guys, that is your Watchman procedure. If your patient doesn't have that yet, or if you happen to hear that, hey, this patient has a Watchman procedure in the past, and that's what the intention is, just to secure this appendage in here. Heart failure, of course, what's going on with the heart failure? We all know that you have a left-sided heart failure. It goes into, having a ejection problem, right? Squeezing problem. So what's going to end up happening, there will be a backflow. So they're going to start having some pressure into the left ventricle, LVH, left ventricular hypertrophy, and then the left atrium has to work really, really hard to push blood into the left ventricle. So the left atrium then it's become hypertrophied, and that is what we call the LAH. And then if there is a lot of pressure into the left atria, then the pulmonary, of course, has to overwork, and that create the pulmonary hypertension too. So that is, and if the blood is not flowing really well, what we call the pulmonary edema. So again, guys, these are the reasons why we really need to look at heart failure seriously in terms of like these patients that are going for open heart. MI, we all know that MI, if you have a myocardial infarction, then the tendency is for your EF to be affected. So if your ejection fraction is less than 50, then the tendency is the heart is probably become hypodynamic. So the contractility is not as good as when you don't have MI. Thromboembolism is the same as what I mentioned a while ago. If you have some thrombus sitting in there, the tendency is to get dislodged, and then it can create some sort of a either stroke or any kind of obstruction. I think the most common is stroke. Bleeding due to anticoagulation, especially if they are, I mentioned a while ago, they have previous stents, then they are on Coumadin, of course. Then look at their factor 10A, your XA or your factor 10A if it's high, or your INR if it's high. You have to let the doctor know. Then the greater admission and decreased quality of life, we all know that it's AFib is preventable, as what I mentioned a while ago. Just give them AFib or amiodarone. So the recommendation, again, beta blockers should be prophylactically in all. So let's see here. So this is your beta blocker here. And then the patient undergoing, unless they are contraindicated, then you give them the sotalol. So again, guys, it's very specific to the organization and your cardiothoracic surgeon. Amiodarone should be used for prophylaxis, as I've mentioned, and biatrial pacing significantly reduces the incidence of atrial fibrillation in patient undergoing cardiac surgery. So I am going to actually question this because a lot of surgeons don't even want the nurses to touch the pacemaker, especially if the epicardial wires is attached to the pacemaker. But where I came from, we train the nurses on how to look for and on how to actually do the pacemaker settings. Especially when we say your daily checks, right? Is the current pacemaker settings is still okay or no longer okay. So again, guys, I would leave this to your hospital policy, but just to give you an idea that sometimes your epicardial wires, and I ask many nurses about it, so if they're coming out like this, for example, so the silver one is usually gray or silver is the positive, and then the white is normally the negative. So why? Well, some nurses that I asked randomly, they said, oh, it doesn't matter. That's what the OR nurses told me. Well, they are the OR nurses and you are the CVRN. Would you believe, like, for example, just asking the gardener on how to cook a good spaghetti? Yeah, are you going to ask the gardener versus the chef, right? In terms of those. So again, guys, if you're reading the label for the epicardial wires, specifically, it's saying in there that the white is the negative and that the silver or gray is the positive. So when you put them in the appropriate clip, so when you have the your pacemaker, then positive will go to the positive, negative will go to the negative, right? So this is your gray or the metallic, and this is the white color epicardial wires. Again, let's advocate for the right thing to do, okay? So that's just my 2 cents, because I have seen that very consistent at the bedside. If we get the CV surgery patient, that's the first thing I check also. And if it's wrong, then I switch it, okay? So pre-operative assessment, cardiac catheterization, EKG, labs, carotid ultrasound, pulmonary assessment, your pulmonary function test, your ICS education. So you're going to be working side by side with the RT here. Although sometimes respiratory therapists are busy, and it's still going to be our responsibility as a nurse, as a CV nurse, to really assess this. So cardiac catheterization, I should know if this patient before CABG, if he or she had some PCI done, right? So those are the things that I need to know. So who's going to give you this information? Well, the anesthesiologist, when he gives you a report. Some hospitals, they actually have those what we call the pink slip that they fax, but some hospitals don't no longer have those fax machine, or you can see it in your Epic, like in your EHR, electronic healthcare record. So those are the things that you need to pay attention. EKG, what is the underlying rhythm before this patient went to get a cab, right? Is it anteroseptal MI? Is it lateral MI? Or is it the whole, the whole V1 to V5 or V6, those kind of things. And then, of course, labs. So hemoglobin hematocrit, pay attention to that. Your K, your sodium, and also your BUN and creatinine. Calcium also, especially when they get so much blood transfusion, the tendency is your ionized calcium is going to go low. And so what you need to do is you just have to do blood transfusion, and of course give them the calcium, calcium chloride or calcium gluconate. So it all depends on the doctor's order. Pulmonary assessment, again, as what we talk about, it's important that your patient can able to take a deep breath in, and so that we can meet that 4 hours, before 4 hours extubation. So another elements of open heart surgery or postoperative care for an open heart is understanding hemodynamics. So and I mentioned a while ago that this patient is coming out with a PA catheter. We are no longer calling them a Swan Gans, because Dr. Swan and Dr. Gans, I think they're already passed away, and they already sold this to Edwards Life Science, and now they took ownership of it and they call it PA catheter, Pulmonary Artery Catheter. If someone will say something about that, that's what I know. So don't kill the messenger, okay? If you're still calling it Swan Guns, be my guest. I don't really care. Still the same. And probably it's a good thing, because we need to give recognition to the people who actually pioneered and started this before us. So what I normally do, again, I have seen nurses that are not doing anything, and I have seen a lot of good nurses that they're watching the monitor and guiding the doctor. So what the doctor normally do is they're looking at their patient, right? They're looking at the neck. Some doctors are not looking on the monitor because they're looking at the PA catheter. So your job as a nurse is to look at the monitor. So one thing that I want to be very specific is that I know that they put this, some of the catheter are being put in the OR by the anesthesiologist, but sometimes it can happen in the CV/ICU, right? As a CV nurse, you should know how to assist the doctor in putting a PA catheter. So first thing is your monitor, it needs to be on the, just like your iPhone. Where can you find Facebook? You go to the Facebook app. So it's the same way here. If the doctor will float a Swan Gans or a PA catheter, you need to be in the PA catheter modules of your monitor, or what we call a the PA. There is a PA monitor, and then it will actually first thing that the doctor would do is just like putting a central line in the introducer, right? So you give that to them, aseptic technique. Everybody's supposed to be wearing hat and mask, and you need a timeout, right? So that's our universal procedure for that. And then as the tip passes to the right atrium, you see a CBP, right? What do I mean by that? So the doctor put and then you see a CBP like this. The A, C, and then the V, right? And then the X descent, and then the Y descent. So this is your CVP. So CVP, then you need to inflate the balloon and keep it inflated. If the doctor did not say that, you just say, hey doc, I'm going to inflate the balloon, now you're on the right atrium. Boom. He'll agree with you because that's the standard. That's what we do. Why? Look, you inflated it here so that you won't be poking your tricuspid valve and tendency of the injury, right? You prevent from injuring the valves. And then and it's easier to float because there's a balloon, right? So that's the whole point of this is when Dr. Guan, I think Dr. Gans was in Santa Monica Pier, he saw there was a balloon just going with the wave, floating with the wave, and he got the idea. So when you floated it here into the right ventricle, you then see a upstroke and downstroke waveform like this. The only difference is you don't have a dicrotic notch. So you cannot keep this PA catheter longer into the right ventricle, or else you're going to create a PVC, right? Premature ventricular contraction. So the tendency is it will advance into the pulmonary artery system. So when it passes your pulmonary artery, right, pulmonic valve, then you will then see a dicrotic notch. You would then see like this. So this is your dicrotic notch, then you are on a PAP. So that's your pulmonary artery pressure. And so the normal CVP is 2 to 6, right? The normal CVP is 2 to 6. So this is what I was mentioning on your right ventricle. The normal is 15/25 over 0 to 8. So if you're getting your CCRN, they love to question you with this type of, hemodynamics. And then there is your dicrotic notch that I was referring to. Then the number now here goes a little bit higher. So 15/30 over 8/15. So this is your magic number, 30/15. Again, what happened is as soon as a doctor was introducing this balloon, so when the balloon occluding the pulmonary artery, pretty much you are measuring the pressure in front of your right ventricle, right? So this is the lungs, and then the pulmonary vein into the left atria, and when the mitral valve opens, the left ventricle. So that's the beauty of this pulmonary wedge. If your Swan-Ganz or PA catheter is the balloon is inflated, you're occluding the flow, and there's no flow coming in, but the sensor can now seeing what's in front. You are now seeing the pressure and feeling the pressure of the lungs, and then you see the right atrium, and then when the mitral valve opens, you're pretty much seeing the pressure into the left ventricle. All right, so that's why pulmonary artery pressure, especially when you wedge, is really important determinants of your left side. However, some of the doctors don't want their nurses to be wedging, right? So what is your alternative number if you don't wedge? Then this is what we call pulmonary artery diastolic. So the pulmonary artery diastolic, if it's 15, it is normally higher, at least 2 to 3 millimeters per mercury than your normal PAOP or your wedge, which is 6 to 12, right? So if you have 15 in there, guesstimation, that's fine, at least you know that it's probably, your PAOP is probably 12. But sometimes those numbers don't remain low, right? They don't remain low, they are high, especially, again guys, what what condition that could actually trigger these numbers to go high. If your PAP, especially your pulmonary artery pressure systolic is 60 and then your diastolic is 40, oh boy, that's really high. So think about pulmonary hypertension, right? Or think about some of the reason why they have that, either pulmonary embolism, or could it be the left side problem? So again, I want you guys, that's the reason why some hospitals, they want to wedge, because if I wedge and I only got 12, then I don't have to blame the left sided of the heart, right? You don't blame the left ventricle, you don't blame the left atria, because their number, the PAOP is 12, but my number in the PAD is 40. So if my PAD diastolic, pulmonary artery diastolic is 40 and my wedge is 12, then that is it's telling me that it's more pulmonary and not cardiac involvement. Okay, so that's one thing that critical thinking as an ICU nurse, you should be able to differentiate that. You do not blame the left side of the heart if your PAD is 40 but your PAOP is 12, because your wedge is normal. So you're looking at the wedge, right? You inflate the balloon and then you're isolating the pressure. Then you are now saying, well, the pressure out there in the left atrium and left ventricle is good. It's only 12. So the pressure, but when you deflate me, then the whole pressure is really high. Then it's someone here above me, which is the lungs, right? So that's just my 2 cents. So there you go, guys. Sees what's in front of it, left side of the heart. And I think I already discussed this. So if you're struggling with your hemodynamics, then I want you to pay attention and review it again, because this is what we do as an ICU nurse. We all look at the monitor. The monitor is giving you those numbers, is telling you stories about your patient. Don't ignore them, okay? And of course, if you don't try to investigate further, if you're just relying on what you see and you don't play with your monitor, then this is, I challenge you to really practice more, because as an ICU nurse, that's what we do. We don't look for normal. We look for abnormal, because if it's all normal, then this patient doesn't need to be in ICU. Transfer them to step down, okay? As a nurse, you are really trained to look for abnormality. And then this is when you are actually relaying it to the doctor ahead of time. So again, guys, a good ICU nurse should be able to differentiate the normal from abnormal from normal, and you're looking more on the abnormality before it becomes so big that it becomes so obvious, right? If you're that nurse who are just seeing the obvious, well, you have to really train yourself more to see the minute changes before it became so big and it became so obvious. Okay, so I challenge you with that, because I have seen a lot of nurses still doing that, like, oh, I'm the only nurses who work here because every time I work here I have always cold blue. Why is it like that? Well, when you have cold blue all the time, you're not doing a very good assessment, because before you call a code, you could have at least identified something is not right and then fix it right there before it becomes too late, right? So that's just my 2 cents. So the length of your insertion, it's between 45 to 60. How do I know if it's 45? How do I know if it's 60? In each line, you have those marks, right? If you see a very fat black mark there, that is 50. And then there is a very, like another black marks in there, but it's not very fat or very just so slim, that's 10. So that's already 60. And then of course 70. So probably in between. So that is 65. Right? But some doctors don't do it like that. They just stop where the black marks there, like that. All right, so 60 is our magic number. 45 to 60. Make sure it's secured, okay? So this plastic covering here, oh, I don't have it here, but you do have plastic covering, right? And this is expandable. So this is your plastic here. When you twist it this way, there is that securement in there So you have to twist it to secure it so it won't move. So again, that's a safety feature that ICU nurses, CV ICU nurses would look for, okay? Make sure it's secured, it's all tight and not tagged, and it's not being pulled, or else it will migrate, okay? However, sometimes you see a fling, like, you know, like I call it the burst, like in Abu Dhabi, there is this hotel in there, you know, anyway, forget that. Erase that. So it looks like this. So that is fling. So what we do with the fling, F-L-I-N-G, is we just tell the patient to turn on the left side, right? So just turning them on the left side, left lateral position, you're able to pull, hopefully that PA catheter get pulled a little bit back, then you don't get the fling anymore. So again, guys, make sure that your catheter is secured. So what influence your PA measurement? Well, again, guys, if, for example, your PEEP positive and expiration pressure is more than 5, that is, especially if it's higher than like 10, there is a special formula to adjust your PAOP, your wedge pressure, okay? So during inspiration, it decreases intrathoracic pressure. It decreases because you inhale, right? So there's more negative in there. Well, there is positive, but there's also some sort of like a more suction. So that's a decreased intrathoracic pressure. And then when you exhale, you increase the intrathoracic pressure. So what do I mean by this? Your PA, your cardiac output, your wedge will go down during inspiration. And your PA, your cardiac output, your cardiac index will go up during expiration. So that's why we always measure your, when do you measure it? During inspiration or at the end of expiration? So we always measure it at the end of the expiration. So when there is a slight relaxation, right? There you go, that thing, before I inhale again. So that is your PA measurement. All right. Oh, it says here, it reads at the end of expiration. All right. So don't forget that, because I always randomly ask the nurses and they don't know how to answer that. So I'm glad that I'm giving you this, although some nurses said, oh, Manny, your videos are boring because you kept talking. Well, I don't dance and I don't sing, but I talk about and share experience. So in order for you to be able to understand this video, you need to have your RAS, reticular activating system, fully engaged. You know, a part of your brainstem, your RAS needs to be awake and stimulated. And how do you do that? You take a deep breath in, because RAS is also responsible for your respiratory rate. You're breathing in and out, right? So when I say you need to be awake, take a deep breath in, you have to engage your reticular activating system, needs to be fully engaged so that you can able to understand what I'm saying and able to retain it. If you're weak in neuro, then this is something that I encourage you to review your neuro. So hemodynamics interpretation, again guys, your preload is a direct measurement of your proximal port, or your blue port, that is your right-sided heart. So the way I understood this is, if this is my inferior vena cava and superior vena cava, right? So this is your superior vena cava, this is your inferior vena cava, and then this is your right atrium here, right atrium, and then your right ventricle is here, right? This is a tricuspid valve. So this is your preload here, okay? So whatever volume sits here is what we call central venous pressure, your CVP. So normally our body has a zero pressure here, so that the zero gradient, right? So any pressure on your lower extremities and your upper extremities, then it will just gonna empty into your right atria. So that's why we call zero gradient, right? So some books would say your CVP is 2 to 6, 2 to 4, but normally it's 0 because you don't have any pressure in there, so that it's just going to keep dumping the blood, the venous blood from the lower extremities and the right upper extremities into the right ventricle. All right, so how many of the doctors really want to use your CVP? Well, it's just a reference point. It's not really something that I would pay attention and or that I would treat, because if you're thinking about like fluid resuscitation, for example, do not use your CVP as a measurement for that. You can just say, hey, doctor, my CVP right now is 6 or 8, right? But the blood pressure is still low. So what is that? So again, guys, you do some sort of like alternative course of intervention. So what I'm gonna do is, if that's me, I would probably say, hey, can you grab my ultrasound or echo machine, and then you do my IVC, right? So what they do is they try to measure your inferior vena cava pressure. So what you want to see is, if you do the ultrasound, you should see a very stable, well engorged, not collapsing. If you see IVC still collapsing like this during the ultrasound or echo, then your volume is still low. Most of the residents knows that, or even I don't know about your nurse practitioner, but normally I see a lot of residents who bring the they bring the ultrasound machine, and then they actually do that. So we are already training. Where I came from, we trained some of the charge nurses on how to really spot check the IVC. So if this is something that you might want to do in your institution, in your organization, that's really cool. You know, nowadays not just a nurse practitioner who can do that, but I think we should all train our staff nurses, especially our charge nurses, to grab it, and then they can just put it there, and then once they see the IVC, then they can escalate the issue because they already seen it before the doctor. Then the doctor doesn't, well, they always do that, right? They don't believe on the nurses. They'll bring the machine again, but once they put it there and see like you're correct, it's still collapsing like this, then just raise your eyebrow and say, call it a day, right? Because you already told them. So again, guys, but this is something that we're trying to empower you, because you know what you know, and you are advocating it for the doctor to do something. So again, that's how I treat those fluid resuscitation. I don't go for CVP. Well, again, something that CVP is very inaccurate. A lot of literature is already telling us that don't treat your CVP, because CVP is not a total measurement of your volume, right? But if you're just treating it, but if you just have a situation where your patient is, you're trying to fluid resuscitate your patient, then getting an ultrasound and checking for your IVC is probably more definitive to me. It's better guiding your practice than your CVP, because then you say, hey, I don't need any more fluids. It's already engorged. It's already not collapsing anymore. Stable. There you go. And if you don't believe what I'm saying, I think there's a lot of literature out there. You can search for it and read it yourself. Thank you. Hemodynamics interpretation, your cardiac output. So a lot of the doctors don't want to really use cardiac output. They want to use the cardiac index, right? Cardiac index and your SVO2. So I do like the, just for a review, your stroke volume is actually your end diastolic volume minus your end systolic volume. What do I mean by this? So if you have a glass, right? So your end diastolic volume is when you fill the glass. So after you fill the glass, how many is the volume in there? Let's just say 120. And then your end systolic volume is when you squeeze. So there is a squeeze in there, right? So when after the heart squeeze the left ventricle, how many left? So 120 minus 750, your stroke volume is 70, right? So that is the definition of your stroke volume. So again, guys, your stroke volume minus your end diastolic volume is your EF. So I don't know about you guys, but I have seen a lot of nurses who doesn't even, I mean, when I say I have seen, not just one, but the majority of the nurses in the ICU doesn't know this. So I have my calculator here. So if my stroke volume is 70 divided by 120, then my EF is 58%. So, 58%. Is that good or bad? Yeah, it's good, right? It's more than 50%. So again, this is how we understand our hemodynamics. Okay, so that is your stroke volume. But then, of course, your cardiac output is stroke volume times your heart rate. I don't know about you guys, but most of the patients in ICU, they have a heart rate of 120, 130, 150, 80. It's all over the place. So which heart rate are you going to pick, right? Are you going to use? So I asked that question to one of the nurses, and he told me, well, whatever the machine, because I always use to calculate hemodynamics into the machine. So of course the machine will pick the time you did your calculation, right? What if your calculation at the time was like around 12 and it was 78? But then after 12:05, it became 120. So it is really all over the place. So what I normally do is I'll probably will just get the mean, right? Or the median. So if you have like, for example, 87, 97, 107, those kind of things, just get what's in the middle. So that, again, these are the things that we look for accuracy. So that's just my 2 cents. I'm not really so sure. I'm still looking for some literature to address that. But I think for me, just like what we do with research, we put all the numbers and then we get the median number, right? The middle. So that's what we're gonna do with that. And of course, guys, is it regular or irregular? So that's another issue of getting your heart rate there. All right. So hopefully you get the cardiac output. The normal is 4 to 8. There you go. It is 4 to 8 here. And then your cardiac index is 2 to 2.5 and above, right? So please pay attention to with your cardiac index. Some cardiac index of 2.0, I would like to know what's going on there. So that's probably why I don't sit in the chair, because as a nurse, they said, Manny, you don't sit, because I'm always out there trying to investigate what's going on. So by the end of my 12 hours, I burned so much calories because, I did a lot for my patient. But the good thing is I did not code my patient. I was extubate my patient within 4 hours, and he's up in the chair within my shift, right? And then guess what? All of my pressure is supposed to be turned off eventually. So those are the things that, not really off, but at least I'm titrating it down. Again, especially if they're young, they don't need to be in bed. Oh my God, that's a bad practice. All right. So again, guys, these are the things that will ask you to get up and see what's going on. 2.2, 2.1, even 2.2. Some doctors are happy with 2.2, but for me, I would investigate what's going on with 2.1. Is it a tissue perfusion issue? What's my SVO2, right? So your SVO2 is then come back 60 to 80. So if it's really low than 60, then I probably would say what's going on here. However, remember your cytopathic hypoxia, right? Your cytopathic hypoxia that means some of the SVO2, they come back normal, pretty normal, but literally that patient is not okay. So again, there is a lot of debates about the accuracy of SVO2. Is it really an indication of tissue perfusion, right? So I don't know you guys in your hospital, but this is something that we use as a reference, cardiac index and SVO2 in terms of tissue perfusion. All right, there you go. Your cardiac index is a measurement of cardiac output, but it's relative to your patient's weight and height. So you have a 4'11", and you have the 7'4" individual, right? So then cardiac index is what we normally probably use. So the weight and the height is entered into the cardiac output machine, to obtain a PSA. So some hospitals are using the continuous cardiac output, which is the hemisphere. Some are just using their monitor and using the traditional cardiac output when they, push those saline, like cold saline, right? I still like those though. That's the old ways of getting a cardiac output. But hey, technology is nowadays is going with the flow, but our salary doesn't go with the flow. I wish technology will go up, will advance, and then our salary will also, the salary of the nurses should go up too. All right. So afterload is the resistance. So I want to make sure that you guys understand what's afterload. So let's just say this is your right ventricle, right atrium, right into the lungs. And then the lungs perfuse oxygenation rather, right? And then it goes back into the left atria, and then the left ventricle, and into the aorta, right? And then it goes into the arterioles, into the capillaries, and then into the venules, right? And into the veins, and it goes back. So when you say afterload, so this is your RV, right ventricle, it left the heart, it went into the lungs. So that is your right afterload, because it went into the pulmonary. So then pulmonary vascular resistance is your right side afterload. So from here to here, right? So what do I mean by this? Let's just say your pulmonary artery pressure, right? Normally we use the diastolic mean, your mean, pulmonary artery mean. You minus your PAOP, right? Because this is your left-sided preload, right? So minus your PAOP. You divide it by the cardiac output times 80. And that is your PVR, pulmonary vascular resistance. So that's a formula. So your pulmonary artery mean, you minus it by your preload, which is 6 to 12. So the pulmonary artery mean is usually like 8. You minus it by your PAOP, let's just say 6. So that's 2. You divide it by cardiac output, let's just say 4. 2 divided by 4, right? So I'm doing it for you guys. So 2 divided by 4 is equal to 0.5, and you multiply it by 80, and you have 40. Well, that's a very low cardiac PVR. So that's what we normally do as a, when you are really paying attention to your pulmonary vascular resistance. So what is the implication to that? It's a very low pressure. It's not very high pressure. It's a low pressure. It's a very thin structure because the pulmonary artery is very thin compared to the systemic. So what about systemic? So the systemic is from here, right? Your right atria, left atria, and the left ventricle, we know it's a high pressure. So the blood pressure is 120 over 80. So if your blood pressure is 120 over 80, how do you get the map? So 120 minus 80, right? Divided by 3 equals plus 80 is you have a 93.3. So 93 is your map, mean arterial pressure. So when the blood pressure comes out, this mean arterial pressure will be able to penetrate all these arterioles here, which is a very, very sensitive. There's a lot of alpha in there. So you stimulate your alpha, they'll constrict. So for example, in the kidney, within the capillaries, right, the capillaries here, you have a pressure, gradient pressure here of about 20 millimeters of mercury. Imagine if I have a 20 millimeters of mercury and in the kidney it's higher, it's 30 millimeters of mercury. So with my mean arterial pressure of 93, that can actually penetrate it and open it, right? So the pressure is higher to go to the capillaries, and then into the capillaries, it exchanges all this tissue perfusion, let's say your brain, your heart, your kidneys, your liver, your colon, your muscle, those kind of things. So then it will penetrate with the mean arterial pressure, it will open up, and then you perfuse the tissues and everything, and then when it goes to the venules outside the capillaries, then the pressure there is about 10 millimeters of mercury. It's a lower pressure, and then it will go back into the veins and down into your pipeline, into the pipe where it goes to the inferior vena cava. So that is your systemic vascular resistance. There is that resistance. So there's a lot of alpha there, and your beta is only located into your, normally the beta is musculoskeletal, and then the rest are all alpha. So SVR is your mean arterial pressure, and it goes back to here, CBP minus CBP, right? Because it goes back to the right side, divided by cardiac output, and you divide it by 80. So that's how I always understood your systemic vascular resistance and your pulmonary vascular resistance. I don't memorize formula. I just have to understand how it is. So again, guys, pulmonary vascular is your pulmonary artery mean, and of course your PAOP, you divide it by cardiac output, you multiply it by 80. Your systemic vascular resistance is your mean arterial pressure plus your CBP divided by cardiac output, you multiply it by 80. So if you are that nurse who are actually struggling with hemodynamics, that's the easiest way to explain it. As soon as the blood pressure comes out of the left ventricle to the aorta, there's a pressure out there. That's what we call total peripheral resistance, right? The TPR. So the TPR, when you think about your physiology, Laplace method or equate, I think it's the Laplace or Laplace, wherein the diameter of your arterioles and the length of the arterioles has something to do with the pressure, right? If, for example, the diameter is bigger, then the force or the pressure is going to be lower. If the pressure is, or if the diameter is smaller, then the pressure goes higher. So that is the total peripheral resistance in terms of physiological concept. Then of course, if it's longer, just like your water garden hose, right? If the water pressure is low, the only way to make the water really reach the far end of your garden is to, put your finger into the hose, right? So that the pressure will get, because again, the smaller the opening is, the water pressure gets higher. I hope you guys understood what I mean by this, because it makes more sense if you understood that, the diameter is actually the flow, which is Q, is again proportion into the tension or pressure into the radius, right? Tension and radius, and then the tension is like the pressure in itself. All right, so then again, afterload is measured with SVR, and I think we already talked about that, and your PVR. So 8 to 1,000, 1,200. So I think the way you will understand this is if it's too high, too tight, okay? Too high, too tight. Too high, too tight. Too low, too loose, right? So if it's too tight, what kind of medication can you give? Vasodilator. What are your vasodilator? Your nitroprusside, your nitroglycerin, right? And if it's too loose, then your vasoconstrictor, which are your epinephrine, your levofed, things like that, right? So it's really nice that you understand this. So what I like about nitro is it has some arterial and venous vasodilator, okay? So venous and arterial. So it's really good. That's the reason why I've seen nitro drip come, for most of the cases when they came out. They always have nitroglycerin drip. All right, and then of course your PVR is 100, 200 dynes. So again, if the number is like 1800, too high, meaning too tight, it's constricted. If the number is too low, like 600, too low, right? 600, too low, then what's going on? It's too loose. Vasodilation, why? Infection, sepsis, those kind of things, right? Or it's too much nitro. So you have to go slow with your nitro sometimes because you are dilating this patient really bad. All right. So how is right ventricular pressure measured using your PA catheter? So again, guys, I think we talked about that during the insertion of the PA catheter. The doctor will put into the superior vena cava, and then the pressure in the superior vena cava is measured. So that is your CBP. All right? And that is your right ventricular pressure. And then, of course, it will go down to the right ventricle, and there is pressure in there. So the tip of the catheter can sense the pressure. Why? Because if the aortic valve is closed and the mitral valve, tricuspid valve is closed, then right ventricle become a chamber, a closed chamber, right? So what is the pressure in that closed chamber, and what is the pressure when the valves open? So that's why 1525 over 0.8. So what is pulmonary artery pressure? Pulmonary artery pressure correlates with the filling pressure of the left side of the heart. So I want you guys to pay attention with the PAP, because again, it's some book will say 30 over 15, And if the number is the only going up, right? If the PAP is the only going up and your PAOP is normal, so you blame the lungs. The lungs has a problem and not the heart. But if your PAP are high and the PAOP is high or will be high, then the left side of the heart is causing the lungs to have a problem, or both, right? So for example, people who are living with cor pulmonale, right, because of the pulmonary hypertension. So they probably have a cor pulmonale here, cor pulmonale or pulmonal, and then they develop some left-sided ventricular failure. Then that is dual, right, biventricle. So yeah. Pulmonary artery occlusive pressure, indirect feeling measure, it indicates the left-sided volume status. So your normal is 8 to 12. Again, guys, some hospitals don't wedge. If they tell you do not wedge, then your alternative number here is your PAD, pulmonary artery diastolic, which is the 15. Okay, some patient might have 17 or 18. Then make sure that you check that with a doctor, and sometimes they will order for Lasix because it's probably wet. So how does the PA catheter measure PAOP? You inflate the balloon. So again, guys, some nurses probably don't know yet, but the syringe that you use is very special to this PA catheter. It's only about 1.5 in there. You release your hand here, it will deflate automatically unless there's an arrow here, red arrow that says open, and then red arrow here that says close, right? Or open and close. So I think if it's like this, it says close. If it's like this, it's open. So when you push the air in and you hold it here, or you turn this into here, then you don't even have to hold it, then you are inflating the balloon. But we don't want to encourage that. The reason is we encourage you to hold it so that when you let go your finger, it will automatically deflate. That's the safety feature of that syringe. All right? So I discourage turning this. Just keep your finger with the syringe and let go. And then it will deflate automatically. And if you are still seeing a wedge, then you remove the syringe and put it back and aspirate air. Keep aspirating air until you see a like this. Okay, what do I mean by that? See, if you see your monitor like this, you are wedging here. Something inflated the balloon. Could be when you turn the patient and that's the reason why I don't want those catheter to be at the bedside. They need to be out, hanging by the pole. All right. So please check your gadgets. Don't leave them under the patient, because if you're turning them, you're probably pushing those syringes to inflate the balloon. So the risk of obtaining a wedge is air embolus, pulmonary artery pressure, necrosis, right? So imagine if this is your pulmonary artery, then you inflate the balloon and you left it there, there will be a necrosis here, pressure. So measured at the tip of the PA catheter, again, your yellow port is the only port where you're gonna get your mixed venous, nothing else. Don't use that to infuse blood or fluids. No infusion into that yellow port. OMG. When I randomly checked the PA catheter, I saw a nurse. I don't know who could it be but the nurse, right? I saw a medicine connected to the yellow port. Not good. So please make sure you label your ports, you label your tubings so that it's easy to identify the connections, because it can be like a spaghetti there because there's a lot of tubings. All right, and this is what I told you about your continuous cardiac output combo. So why is it mixed venous? Part of the blood is drained from the coronary sinuses into the right atrium after being circulated through the heart. So there are three causes, but I'm just going to share you the two most common one. So we all know that if the blood went into the pulmonary, right, there's a gas exchange, CO2 out, oxygen in. And when it leaves the lungs, it's supposed to be 100%, right? However, with physiologic shunts, it will only turn into like 95. Don't feel bad if you don't know this, because majority of the nurses I ask, they don't know. And so when I explained it to them, I told them, do not forget this information, because I learned it many years ago, 31 years ago, and it's still the same. So what happened here? Why did it turn 95 or lower it down to 95? It's correct, there is a mixed blood, but where are those blood came from? So remember, inside the first source is, I'm just going to make sure that you understand. So the left atrium, right? Left ventricle. And then it comes out into the aorta, right? And into the aorta, there are coronary arteries, of course. Goes to the heart, and there's a coronary arteries because there's a coronary ostia there above the aortic valve, right? Left and right. So the coronary ostia to the left is left coronary ostia to the right is the right coronary. So blood comes out to the aorta, will passively drain into the coronaries to feed the myocardium, right? The myocardial cell. So what happened is it will then drain into the division veins into the ventricles, and that will add the 95%. So oxygenated blood of 100, so there is this unoxygenated blood from the myocardial cells into the oxygenated blood, it drops it to 95. That's first source. The second source is the bronchial artery. So you have a bronchial artery here that will feed your bronchial tree, right? So this is your bronchial tree. So if this is your bronchial tree, then the bronchial artery will then circulate blood into the bronchial tree, and then it will drain unoxygenated blood into the pulmonary veins, right? So that's the second source. Bronchial artery supplies oxygenated blood into the bronchial tree. Bronchial tree will use the oxygenated blood, and then unoxygenated blood get dumped into the pulmonary veins. So that's where you have a physiologic shunts. Physiologic shunt. So don't expect your oxygen blood from the lungs to be 100%. Because of this physiologic shunts, there's two things. It will really drop it into like 95. So when it goes back to the right side, right, it's supposed to be 60 to 80%. It goes back to the right side of the heart. Got it? So that's the mixed venous. So I'm hoping that you understood this. First source is from the division vein. Blood that will flow from the coronary arteries goes back into the division vein. I don't know if it's my accent that they don't understand. Division or division veins. This is N. All right. So that's one source. And the second source is the bronchial tree artery. It goes to the bronchial tree, right? Bronchial artery. to the bronchial tree, drains the unoxygenated blood into the pulmonary veins. All right, then this is your continuous cardiac output. We have a better version nowadays. The Hemisphere at Edwards Life Sciences made a very upgraded, very nice machine, upgraded one. It talks about your cardiac output, cardiac index, and of course your SVR, your PVR. So the diseased heart and a heart rate of 120 may then decrease heart rate function. That's the reason why if your heart rate or you have a rapid ventricular rate, you need to fix this issue because you decrease the filling time and you decrease. So filling time means you don't have you're not giving enough time for the left ventricle or right ventricle to fill. You need to have time for that to fill so that when I squeeze, there's a lot of blood to get squeezed out. Okay? So that's the main point of us decreasing the heart rate. Because also it increases the oxygen demand of the heart. And you don't have a good pipes for blood supply into the myocardium. Then it creates a lot of chest pain. All right? So your mean arterial pressure, I already explained this a while ago. Some hospitals like it 60, some hospitals like it 65. And imagine if my MAP is 60, your CPP is normal is, your cerebral perfusion pressure, the normal is 60 to 80 for your brain function. And if my MAP is 60 minus ICP, which is 5, I only have 55 CPP. Then that's not good. So cerebral perfusion pressure is MAP minus ICP. And I'm just giving you a normal ICP of 5. So if you're telling me my MAP is 60 right now, minus ICP, then I'm probably lethargic a little bit, right? Why is he lethargic? Well, imagine if my MAP is only 55 and you're ignoring it, minus 5, then I have a CPP of 50. Do you think that's good? No, it's not good. So your cerebral perfusion is poor, then your patient is not very awake. Especially if they have stroke, that's not good. You want their CPP to be higher than that. So increase in afterload, hypertension, aortic stenosis, low body temperature, vasoconstriction. So again, guys, what do I mean by increase in afterload? Your SVR. So this is really true, and the nurses gets confused. If my cardiac output is low, my cardiac index is low, my blood pressure is low, my SVR is going to go up. Compensatory. You do not treat my SVR right there because the main reason of going up is my cardiac output is low. My cardiac index is low. That is what you call your catecholamines, right? How your body responds to all this low blood pressure. It's already a program in your system that no matter what you do, that's what they do. They're watching each other. Hey, his blood pressure is low. Let's constrict. They constrict. And then, of course, when you're constricting, they're trying to prevent from blood flow, the loss of blood flow. And they constrict. They're trying to squeeze more volume up back to the heart. Your SVR is going to go up. And then the nurses kept going on their NTG, nitroglycerin. But then look at your cardiac output first, guys. Again, I don't mind, but then some of the doctors said, why are you going up with nitro and why are you going up with your levo? Right? So some people are getting confused. They're going up with their nitro because they're trying to decrease this. At the same time, they're going with their levo because they're trying to increase this. So what happened is, if you're just trying to control your cardiac output, cardiac index, either increasing heart rate with your pacemaker, right? Your pacemaker is probably not even attached, and the patient heart rate is only 60 on the monitor, go up to 80. That will actually help your blood pressure to go up without even going up with your pressors, right? But if your pacemaker is already connected and your heart rate is already 90, then go up with your levo-fed or volume first, right? Look at those. There's a lot of avenues to look for. What is my hemoglobin? If it's low, give me blood. What's my albumin? If it's low, then give me albumin or dextran, volume expanders. What's my urine output? Is it low? Well, I probably need some volume. Then you'll do ultrasound of your IVC. Then I probably need some volume, right? So go that route first. And if that route, because you have to fill the tank first. Again, the doctor does make sure that you pay attention to the INOs, because some doctors, they like their patients to be on the dry side. Some doctors likes it to be on the specific INOs. So again, these are just part of your critical thinking. Critical thinking. Critical thinking. So these are the things that you should have in front of you or on your board, so that when you're collaborating with your doctor, you tell them, hey doc, I have a situation here, S-bar, right? My hemoglobin is only 6.5 and my albumin is this and my urine output is this, but I know you want him on the dry side. He's really dry. It's like bone dry, right? So things like that. So again, guys, you need to be open to any kind of collaboration and suggestion. Try not to be so sensitive. When I was at the bedside, I don't really care. It's all about the patient, not about me, not about the doctor. It's about the patient. And here I am at the bedside, and he's not. He's at home, sleeping, right? But I am at the bedside. I have to give him a better understanding of what I'm telling him. So use your SVS bar, right? What is my situation? Be very direct. My situation is low blood pressure. I don't even say, what is low blood pressure to you? Blood pressure is 60/70 for the last 15 minutes. Wow. For the last 10 minutes, for the last 5 minutes, things like that, because you have your art line, right? Then you go from there. What is your background? So, tell him what's going on. What do you have in there? He has a this, right? He is getting this. And urine output is this, and hemodynamics, PVR, this, SVR, this, cardiac output, this. So that is your background. And then your assessment is, what have you done so far at that point? Nothing works, right? What would you recommend? Do you want me to do this? Do you want me to give him this? Do you want me to bolus him this? Do you want me to blood transfusion? So that is how you go about talking to the doctor, especially the cardiothoracic at night. You do your SBS bar. Okay? So some hospitals, they want the result because they are proactively guided by protocols, right? They already use their protocols or algorithms, and now they're using the result. Well, I've followed all those and this is my result. What do you want me to do next? Then of course, decrease your afterload when you are too loose, too low, right? Fever, sepsis, or you have a lot of vasodilation medications in there. So what are your pharmacology? Again, it can be challenging to some, but some hospitals, I've seen nurses very codependent with the doctors, the NPs, the PAs, right? They don't want to do anything because they just wait for I'm just going to wait for the NP to tell me what to do next. That's not a good nursing care. And I discourage you to do that, because as a CV nurse, you should be really there to care for your patient and proactively collaborating with the doctor or your NP. You do not wait for them to come to you and tell you what to do. So you have your alpha. Only medication that is alpha for now is your neosynephrine. So when do we use neosynephrine? Well, I want you to use neosynephrine, and don't stop neosynephrine if your patient has those intra-aortic balloon pump, right? Or if your patient is still getting MILRINONE, because those are really beta, but they don't have any alpha at all. So you need some support of constriction down there. So that's when I just keep my neosynephrine. I don't know if you understood me, but I said I will only discontinue or titrate my neo down if, number one, I don't have balloon pump, or the patient is not on any MILRINONE. So some hospitals, they do have a policy on guidelines on what to titrate first. So I normally titrate first something that I don't need, right? Something that will give me more problems than gonna help me. But some hospitals, they always say titrate your neo first because it's an alpha. So be my guest. You can titrate it off to off, except for those two things that I just mentioned. If your patient is still on MILRINONE, you need it. If your patient is still on balloon pump, you need it. Again, correct me if I'm wrong, guys, because that's has been my practice since many years ago, and I got those input from my cardiothoracic surgeon. Beta 1, it increase your inotropy, all your beta 1, right? Your beta 2 is relaxation. So your beta 1 is constriction, your beta 2 is vasodilation. And then your dopaminergic is your dopamine. It has a renal and mesenteric artery dilation. Okay. So vasopressors can cause tachycardia, so make sure you pay attention to that. Dopamine is actually not a good medication for me. Every time I start dopamine, even if I just run it for like good 10 minutes, the heart rate goes up really fast, and I end up like wasting the whole bag because I have to stop, right? So that's something that I don't. I always go for Libofed, norepinephrine for now. Used for hypotension in the absence of tachycardia. Low doses for renal perfusion. Again, so this is your dopamine, right? It can increase afterload SVR and heart rate. It can be used as an inotrope. So when you are doing a renal perfusion renal dose, 2 to 3. I don't know. Some hospitals don't follow this anymore. Just give them Bumex or give them Lasix. If it's 5 to 10, it's actually inotropic, vasoconstriction, and then 10 to 20, pretty much like heart rate goes up there. Even when your dose is 5, patient's heart rate goes up really fast. So epi, the new generation of doctors nowadays, I have seen them using more epi than Libofed, and that's scary. Because it used to be in many years ago, we use epi as the last resort because some doctors believe it can cause myocardial stunning or stun if you kept it flowing for a good 3 days. Nowadays, I have seen them like, oh, epi is still ongoing for like almost 72 hours now. Wow, can you not titrate it off and just leave your epinephrine, your Libofed? So these are, again, the doctor's preference. I don't know about you guys, but to me, I normally say, are you sure? Because I need to document that. If something happens, then it's you. Because, again, if the question is, what do you do as a nurse? Did you even question the doctor? No, I did not. Well, you're not a good nurse because a nurse is supposed to be questioning the doctor, right? So that's just my 2 cents. Question it. Are you sure you want an epi rather than leaving the norepinephrine? I would rather leave the Libofed than the epi. Can I turn off your epi, please? And then see what they tell you. All right? Because your epi is a direct stimulation of alpha and beta 2 adrenergic receptors. I know it's used for hypotension, same way as your Libofed, right? It increases your heart rate or cardiac output. So the dose is 1 to 5 mics, and it's usually in some hospitals have the post-op orders in there. So our best friend Libofed, it can cause vasoconstriction. It has some alpha agonists and some beta 1. It increases blood pressure, increases cardiac output, and normally it's used in the vasodilatory shock, like those septic shock, right? And the dose is 1 to 12 mics per minute. Again, some hospitals using it mics per kg per minute. And they can go as, or mics per hour, I think, right? So it's like they can go as much as 30 mics. So just check your policy. So this is our NEO. It's used for hypotension in shock states. The dose is 100 to 260. It increases your SVR. Vasopressin, synthetic they call it synthetic ADH, antidiuretic hormones. Hypotension stimulates endogenous vasopressin via triggers from the aortic and the carotid vasoreceptors. So the dose is 0.01 to 0.04, non-titratable. You keep it like that. It increases your SVR, which may explain decrease in cardiac output. See? So review your pharmacology. Nitrile, it's a direct vasodilator of smooth muscle, arterial and venous, right? It's used for preload reduction and prevent coronary spasm. Your dose is 5 to 10 mics. NIPRIDE, watch out because it can cause toxicity, thiocyanate toxicity, right? And used for hypertension crisis, pulmonary hypertension. So what we use here with pulmonary hypertension is our it's only like not Viagra, but it's the Flolan for your pulmonary hypertension. Dobutamine, they're being used a lot now. It has a direct stimulation of V1 adrenergic receptors. It can cause tachycardia. It will use to support your cardiac output. So dobutamine and MILRINONE, that's what you guys see. Your MILRINONE decrease your preload and afterload by direct relaxant effect on the vascular smooth muscles. Okay, so please be very careful on MILRINONE. Some hospitals, they want you to incrementally titrate down. So if you titrate your MILRINONE, let's say 0.2, and then you titrate it down after 4 hours, 0.1, right? No, it was 0.2, then it became 0.1, 0.5. 0.2 and then 0.1, I should say. Then wait for another 4 hours, then titrate to off. So this is not like every minute titration. Some hospitals, they titrate it every 4 hours or 2 hours. So review, it's not like you play, like you have to remember it has a half-life is 2.3 hours, right? That makes sense, right? Half-life. If you turn it down, that dosage reduction will wait until a while. It stays in your system for a while. So that's the reason why we don't titrate every 5 minutes. You titrate every 4 hours, I think, the safest one. 2 to 3 hours. So ESMOLOL, I don't know if you guys still use this, but it used to control tachycardia with hypertension. And your low dose, some hospitals will give a low dose, and your infusion dose is 25 to 300 mics. Okay? Metoprolol. So your 5 milligrams IV push every 10 minutes. So again, guys, it's a case-to-case basis. Don't push this without an order. You have to ask your cardiothoracic surgeon. All right. Diltiazem, so controlled heart rate. Okay, so if you think about if you still remember your action potential, so your action potential is actually, if we're going to review it again, so the action potential is the resting membrane, right? Negative 90 millivolts. And then what it is inside the cell, is more electronegative because of your ATPases, your sodium-potassium ATPases. So if you don't know what sodium-potassium ATPases, inside the cell, you have 3 sodium out and 2 Kn. So that is your sodium-potassium ATPases. So what happened is, if your sodium is out and the K is inside the cell, sometimes the tendency is for the K to leak out. And when they start leaking out, your cell is becoming electronegative, very electronegative. That's when your heart's starting to rest, okay? And then there will be a threshold, because no matter what, sodium likes to go in to enter the cell, right? So when the gate is open, for example, this is your gate, sorry, if this is your gate, closed, right? So the gate is partially open, but it's closed in here, so there's nothing coming out. However, the potassium, when they leak out, that's when the sodium started to enter. So when the K leaks out, sodium enters. So when that happens, it will have the threshold of negative 70 millivolt, and then more sodium going inside the cell, and then it triggers, right? It triggers into from negative 70 into like 0. And then what happened here is, this is your phase 1, phase 2, right? So the calcium channel open, calcium more, your calcium has 2, and then your K will go out. So there's a balance. So there is a balance between calcium intake and potassium loss. And this is where you say calcium channel blocker. You need to block this calcium channel here, all right, so that you don't speed up the heart rate. So that is your calcium channel blocker. Diltiazem is your calcium channel blocker. So used for SVT, rapid AFib, or flutter. So dose is 5 to 15 milligrams per hour. So either drip or you push. Same way with the hydralazine. Some hospitals will give hydralazine first, especially if the blood pressure is really high. Amiodarone, we talk about it, 150 bolus over 10 minutes, and then you start your 1 mg per minute